Welcome everybody to this EURO-NMD webinar that is organized in collaboration with European Reference Network for Rare Neurological Disorders, EURO-NMD, and with the European Academy of Neurology. Today, we are going to talk about muscle ultrasound, the biomarker for muscular dystrophies, and our speaker is Professor Nens van Alphen from Radboud University Hospital Nijmegen in Netherlands. Nens is Associate Professor of Neurology and Clinical Neurophysiologist from the Radboud University Medical Center. And she's been a certified neurologist since 2004, is the medical director of the Clinical Neurophysiology Laboratory and coordinator of the Clinical Neurophysiology Residence Training Program. Her areas of expertise are neuromuscular ultrasound, peripheral nerve pathology, brachial plexus neuropathies, and electrodiagnosis of neuromuscular diseases. The lab that she directs performs more than 1,200 nerve and muscle ultrasound studies yearly and receives visiting clinicians from all over the world for short training programs in neuromuscular ultrasonography. So that's an information that some of the attendants may want to underline. Currently, Nens is focused on advancing muscle ultrasound and developing a national teaching and quality program for neuromuscular ultrasound nationally and internationally. Thank you very much, Professor van Alphen, for attending and giving this talk. We are really waiting to learn a lot today, so thank you for accepting to teach us that something.
Thank you very much for the introduction, and I'll just start off by sharing my screen with you. And I hope you can see it now.
Yes.
Good to know. So yes, today we are going to talk about a slice of neuromuscular ultrasound because we're focusing on muscle ultrasound specifically for muscle dystrophies and its use as a biomarker. And along the way, we will also discuss some new developments in this area. So here are my disclosures, and everything that I earn goes to my employer, the Radboud University Medical Center. Now, why should you do muscle ultrasound, or why should you consider using it for your neuromuscular patients? Well, basically, it's been around for 40 years, started in the 1980s, and there's been a massive development going on, especially the past 10 years. And if you look in PubMed, you can find over 300 peer-reviewed publications. Just for reference, I think for muscle MRI, you can find about 600 of them. And they include systematic reviews at this point, prospective clinical studies, and biomarker work. So it's a very active area. And I think when it comes to the biomarker tool, it's been most actively researched in dystrophies and ALS. It's also used as a screening tool just for any neuromuscular disease. And we will spend a little bit of time on that, but we'll focus on the biomarker issues. So, for me, it's a very versatile tool, and that's why I always try to liken the ultrasound we use in the neuromuscular clinics to this Swiss Army knife. There's a lot of functions and there's lots of things you can do with it. It's always handy to have with you. The other reason is basically this photograph. I think ultrasound is a very attractive alternative for patients as a screening tool. You don't need to stick needles in people. You don't need to put current on the skin. And it gives you a very good diagnostic value. So it's an excellent first-line tool for screening and a very nice follow-up tool for repeated measurements. Now, it is not as different from MRI as you might think at first, because just like MRI of muscles, it's not one technique, it's multiple techniques and applications. And just to provide a brief overview here, you can scan obviously every body region, every muscle that you can you can scan in the face and the trunk and the diaphragm, the limbs, obviously. And if you've made an image, then you can do grayscale analysis. So how black or white is the image, but also the texture. Can I see its muscle tissue or is it being destroyed? You can do pattern recognition if you scan multiple regions, just like you do clinically to see if something is, for example, a limb girdle distribution. There's new techniques like elastography and 3D analysis, automated movement tracking, and deep learning is very on the move, so to speak. So we're going to do some sort of tour here, but for those of you who might be accustomed to MR and have not yet tried or heard from ultrasound for imaging muscles, this is not another technique. This is the other technique at this point in time. And it can really have additional value to the other tools that you already have in your labs. Now, how do we look at muscles? First, this is just a very short scan demo of the protocol we use for rectus femoris. You see the subject lying supine. You see there's a very tiny marker here on the skin right there. It's a measurement that we measure at a predefined site, usually at the site of the maximum bulk. And then the technician, in our case, puts the scanner on. You can see the image appear there. You can see rectus femoris beautifully, vastus intermedius. We freeze the image. We annotate, obviously, and then we take the probe off. And we do this 3 times. So we capture 3 images every time for reproducibility of our measurements. This is just a very short example. So, and the idea behind muscle ultrasound basically is that it's a story of 256 shades of gray. I mean, the book is a few years old right now, but it was much less interesting. And if you can sort of understand what is on this slide, I think you will be fine using muscle ultrasound as a clinician, because you see 2 images of the calves here side by side. There is a medial gastroc here in the image. I think this is, sorry, I'll annotate the anatomy for you. This is the skin subcutaneous layer. This is the muscle medial gastroc, and this is the soleus, obviously. And this is a neuromuscular disorder. So skin subcutaneous layer, and then a very white abnormal looking muscle, and it's hard to see through that. If you can appreciate this, I think you have most of it already in your pocket. And what's happening here is that the ultrasound makes use of the reflection of sound waves. And in normal muscle tissue, these muscle fibers, they are not very reflective. There's not a lot of connective tissue elements. There's a fascia lining here and there, but usually muscle itself, like here in this tibialis anterior areas, looks very dark. Now, if you have pathology, so like in this case is a tibialis anterior of a patient with FSHD, muscle dystrophy, then all these regular muscle fibers are either replaced or interspersed with fat and fibrosis. And that means that you will get reflections every time this tissue changes. So you see here a tissue with a lot of reflections, ending up with a lot of white pixels on the screen, so very white. And also most of the ultrasound is already caught in this dense upper layer, so not a lot is coming to these deeper regions, and that's called attenuation. Now, if you sort of go from there, you can, I think, appreciate why in the 1980s they already devised a grading scale for muscle ultrasound. Sidney Heckmat did that with his group, where they said that, you know, normal is a dark-looking muscle, almost the same as the subcutaneous layer. You can see its muscle tissue, you can see the fiber directions, and you can see through it. So you see the underlying bone. So those 3 axes are what you use to grade muscle images. Now, in a type 2 or grade 2 muscle, you can still see its muscle, you can see through it, but it's lighter or brighter. So the echogenicity as a whole has increased. There are more reflective elements in there. And in grade 3, this is not even brighter per se, but the muscle architecture is slowly being destroyed. So it's harder to see this as muscle tissue. And the sound is not getting through those deeper layers. So there is attenuation. You can still barely see this bone edge here. And grade 4, that's a totally white muscle. You can't see through it. Now, there's more that you can do, and visually, I think you will do it, than just looking at the echogenicity levels and attenuation, because you can also look for patterns in these muscles. And here is a slide with some image examples of a typical dystrophy. So this is again FSHD, where the muscles take on this rubbed out appearance. So like someone colored them with a pencil and then put an eraser on the paper and tried to rub it out. And that diffuse echogenicity increase is very typical for dystrophy. If you have a muscle like this flexor carpi ulnaris here in the forearm, you can see that it's a beautiful oval muscle and only the bottom half of it is white. And that is what you see in inflammatory myopathies, or myositis in this case, that parts of the muscle become affected. And this is relevant, for example, for your biopsies, because you don't want to biopsy the normal half. You want to biopsy the affected half to give you a diagnosis under the microscope. On the right here is a typical pattern for a very long-standing neurogenic problem. So this is a patient with spinal muscular atrophy type 2. This is a biceps brachii muscle, and it's very white. There's a lot of fibrosis in here, but you see these holes or these round areas, and that's actually the remaining large motor unit territories. So this is a very typical pattern for long-standing neurogenic disease with denervation and reinnervation. Here you have fasciculations. This is a biceps brachii lying on a brachialis and then the humerus. And obviously this is not a normal muscle. It's much brighter than the subcutaneous layer. So this would be in Heckman grade 2, maybe even 3. I'll just start the video here. And you see all these tiny jerky movements going on in these muscle tissues, and you can't predict them. You don't know where the next one's going to be or when. Now that's very typical for fasciculations. It's a chunk of muscle and it's random. So this will go on for a very long time, as long as the video plays. And this is a patient with ALS in the diagnostic phase. But you can go smaller. It depends a little bit on the equipment that you use. But if you can have high enough frame rates, so this is 20 images per second at least, and you can turn smoothing software off in your image, then you can also see fibrillations, which are actual moving muscle fibers because of the denervated status. This is a zoomed in image of the rectus femoris in an acute myositis patient. And when I turn the video on like this, you can see all these tiny trembling movements just beneath the fascial lining. So at first you think the person scanning has a tremor, but it's actually the top layers and the subcutaneous are still. It's just that trembling underneath. And that is what you pick up. It's fibrillating muscle fibers. So it does need some special equipment and settings, but you can see it. Now, let's move on to the muscle ultrasound universe at this point in time. There are some beautiful but also exotic looking planets in here, and we're going to visit them one by one. So a couple of things that I'd like to show you and discuss with you maybe later is just what's known at this point in time about image analysis, the diagnostic value, obviously, artificial intelligence, and also biomarker use. So I'm going to visit a few of these beautiful looking planets. And let's just start with the basics. So this is a still ambulant boy with Duchenne muscular dystrophy. And here are images that are corresponding to his disease phase. So even if you haven't seen a lot of these images, this is biceps brachii, tibialis anterior, vastus lateralis, and then gastroc medial. And the only thing to remember is that, especially in young kids, this really needs to be, this is subcutis, the muscle needs to be as dark as that region. And it's brighter in every muscle you see here. So if you were to have one of these handheld scanners in your outpatient clinic, and this boy would walk in, you would very easily put the scanner on his muscles and see that something is going on and directly send him on for further testing. Now, even at a very young age, this disorder can be very asymmetric. So this is a 3-year-old boy with Duchenne muscular dystrophy. And the left image here is showing the right calf is already abnormal. And there's been research work by the group of Craig Zaidman in the US that shows that the ultrasound will become normal more than half a year before they become clinically symptomatic, these kids. So it's a good screening tool. But on the right, you see an Heckman grade 4 completely dystrophic muscle already at this age. And mind you, the thing that is most striking to me is that there is no atrophy. The volume is intact, but it's just not muscle tissue anymore. And that is very typical for Duchenne's. There is never any atrophy. Atrophy is not a good marker, but you can still see the abnormality very clearly. So this is a woman that's being scanned here. It's her thigh region. And we're scanning the rectus femoris, and you can already see it's a very abnormal looking muscle. It's not, the video is not very exciting because she's lying still, But what we need to do here is we can't even see the bone. So to gauge the image depth and the size of the muscle, you need to adjust the depth of your scanning system, just to show you how bad it can be. Now, some other examples. Here's some more inflammatory myopathy examples for you. On the left, you see acute stage myositis, and that's a bit of a peculiar image because this is biceps brachii lying on top of brachialis, and then the humerus. Everything is in clear view, it's bright, and the muscle as a whole is much wider. So this is what's called see-through echogenicity increase, and it reflects edema in the muscles. So it's brighter, but there's no attenuation. That's typical for edema, but it's not very sensitive. So in practice, if you really want to know if there's a myositis flare, it's better to do a stir MRI because it's much more sensitive. It's about 70% versus 90 plus, right? Biceps brachii on the right here is focally abnormal. So again, this muscle here has a part which is clearly too white and you can't see the muscle structure that well. So again, this is a bit longer standing myositis. Now here is just to show you the variability in the involvement. This is vastus lateralis in 4 different myositis patients, ranging from completely normal HECMAT grade 1 to completely abnormal HECMAT grade 4. And myositis patients do have atrophy, so the muscle will become thinner. So this is also to show you that grading system in practice. Another trick that you could use to discriminate patients with inclusion body myositis is that you can really easily compare in one slice or scan the deep and the superficial finger flexor compartments. So here you have flexocarpi ulnaris, which is not completely okay, but it doesn't look as bright or white as the deep finger flexors. And that discrepancy is telling that it might be IBM. Obviously in the right clinical setting, right? So this is an elderly patient with slowly progressive weakness, no pain. Now, one of the nice things we also do is that we have a handheld scanner, and we also have a cart with it's very, very mobile, one of the other machines, that you can use it for ultrasound guided muscle biopsy. Because basically, if you take that HECMAT grading scale again, on the left is a completely normal looking muscle. And if you biopsy that, it is a big chance of you getting histology results saying it's normal muscle tissue. But if you biopsy the muscle that's shown on the right here, it might be that your pathologist says it's just fat. So you don't want that. You want a grade 2 or grade 3 muscle and take parts from that. What I have here is a small video of an ultrasound guided needle muscle biopsy that we perform. It will take 2 minutes. But what we do in practice is that we help our clinicians, we pre-scan the muscle of interest in the room where the patient is at that point for the biopsy. We both scan for visual abnormalities, so HECMAT grading, but also, as you see here, for any vascular structures that you might want to avoid when you stick a biopsy needle in. Now, this is the deltoid of the patient in question, and you see it's HECMAT grade 2 to 3, so that's excellent. We mark the spot and we mark the entry point, and the entry point is anesthetized with lidocaine. Then we use these Bergstrom needles, and they are inserted through a skin incision. And then the clinician has already seen how deep the needle should go from the ultrasound image. And when it's at the right spot, we check using sterile gel the needle tip position. And I'll show you an example of what that looks like on ultrasound a little more clearly a little bit later on in this video. So when we verified that the needle tip is in the muscle, then the biopsy can go ahead. Now here you see the scan image. This was a woman suspected of myositis. Here are the anatomic areas, and there's a focal area in the rectus femoris, which is here. And then we put this biopsy needle in, and you see the artifact. It's a very big needle, but we are not aiming for a 90-degree angle all the time. So sometimes you see it like here, and sometimes it's you just see the movement. And the needle is inserted until you're right in the middle of that abnormal area. Then this is the modified Bergstrom technique. So suction is applied to draw some muscle into the needle window, and then it's cut off by the inner cannula. And so when the clinician has the sensation that there is enough muscle tissue in that window, the needle is extracted. and the muscle tissue is released onto a sterile field, and this is the result. And we do almost every muscle biopsy like this, always with sufficient results. So let's look at state of the art, just going from the practical to the more theoretical evidence. If you want a free to read review of muscle ultrasound, I could recommend this piece that I wrote with my colleague, Jurt Wijntjes, who is our PhD candidate and a clinical neurophysiologist. Just some examples. So this is a woman of 26 years old with a very severe congenital myopathy. And you don't need to be an expert. If you put the scanner on, you see that something is not okay. And this would be, again, excellent screening, but you can also use that for follow-up of this patient or for counseling for maybe rehabilitation purposes. If she has no remaining biceps tissue, we need to find ways to overcome that impairment. So just two images, grade 4 and grade 3 here for her. And if you are just eyeballing the muscle like we are now, your maximum diagnostic sensitivity for detecting abnormalities will be around 75–80%, a little bit depending on your experience. So that's okay as a clinical screening. It might probably be better for a research tool, because sometimes, like here, it's difficult to gauge clinically or visually what's going on. So these are the two biceps muscles of one patient, a male in his 40s, and he was suspected of a genetic muscle dystrophy. Well, if you look at the image here on the left, which is his right biceps, I think it's clearly abnormal because there are these patchy whitish areas, which might very well fit with a muscle dystrophy. But this one, I'm not sure. I mean, I can see it's muscle tissue. I can see through it. It is, I don't know, it's not much brighter than the subcutis. So in this case, you want some extra sensitivity. And that can be obtained by quantifying the results. So that's what we do with grayscale analysis, and other groups use backscatter analysis, sort of a similar technique. We take the image to a graphic program like ImageJ, which is freeware, you can download it. And then you select this region of interest, the red rectangle, and then you have the software calculate the histogram. So how many black, which is 0, to white, which is 255, is in this muscle. And the mean here is 42.9. So you have a value that you compare if you keep the scan protocol similar from one day to the next or from one patient to the next, if you have reference values. We use this in practice a lot, but the reference value part makes it very cumbersome and difficult because every system, every software setup needs its own reference values. So you need to collect those if you have a new system or machine. And that's time consuming for most centers. But it does help because here you can see that if you compare these muscles, then the one on the left was clearly abnormal, 4.2 standard deviations above the mean. But the one on the right is also not okay, it's 2.6. So this helps you in these difficult cases. And then if you quantitate grayscale analysis, again, with an example here of the histogram function and that backscatter technique, then your sensitivity will be 90 to 95%, which is a big step up from the 75 with visual. So again, showing you this involvement in FSHD. This is a 9-year-old male. And so I think you don't have a problem at this time by looking at this rectus femoris, which is not okay. You can have the other vastus muscles for comparison. And this one is too white and it's also thin. But what about that? Yeah, I'm not sure because it's slightly brighter than the vastus intermediate. But is it bright enough to be abnormal? Well, if you quantify it, it's getting there, I'd say. It's a 1.8 standard deviation above the mean. So that is a muscle to track over time. And you'd expect it to become abnormal because this is a genetic dystrophy. Okay, so what about the diagnostic value of that quantitative screening? Well, there's been a lot of work from 10, 15, maybe 20 years ago with these values that I just showed you, very high sensitivities. But a couple of years ago, we decided to repeat the process in the age of next generation sequencing, because basically any ordinary Duchenne kid is not very likely to walk into our screening clinic at this time because they almost as soon as the clinician thinks this is Duchenne's, they will get a genetic test. So right now, the population that you see for the extra tests is a little more diffuse. So we had a cohort in the Mayo Clinic in the USA with kids with all kinds of disorders suspected for a neuromuscular disease. And in the end, if you use the good old protocol with cutoff values from the previous studies, that was actually gave you the maximum sensitivity and specificity here. And these are still very acceptable screening numbers. Mind you, what we did see is if you have here non-NMD, those were usually kids with central nervous system pathology like cerebral palsy, which also gives transsynaptic degeneration, or very obese children because they stack fat in their muscles, and that will also increase their whiteness. So there are a few pitfalls, and this is a bit of a busy slide, and I do not expect that you will remember all of these and sort of be an expert in one slide. But there are several things to take into account when you start scanning yourself. Usually you have one ultrasound system, and that's good because if you use two, like these two images here, you can already see the difference. This is exactly the same muscle, exactly the same person in time with two different machines. The scan angle, so the probe needs to be really 90 degrees to the underlying bone or fascia. If you don't do that, you tilt 5 degrees, you get a much darker image, and that is bad for reproducibility. Now, here are some examples of the influence of age. So this is a young person, 5 years old, 49 years, and 75. And you see slowly that we become tough. You know, our muscles accumulate fat and fibrosis as well. It's called sarcopenia. So you need to keep in mind that elderly people can have HECMAT grade 2 muscles, which are normal for their age. And the same as if you have a high BMI. So this is the BMI of 22 with a subcutaneous layer showing here. And this is a BMI of 36. And then people also stack fat in their muscles. So this will be brighter. This is the old HECMAT image that they used to make the grading scale. That was a very ancient ultrasound technology with low frequencies, and it looks like sonar, basically, like the bottom of the sea. So right now, the ultrasound systems are totally different, and you get scattering of image, which gives you different, the quality of the muscle is different than in the 1980s. And sometimes it's not really possible to use a HECMAT grading. If you have a muscle like in the face, it will never be thick enough to give attenuation of the underlying layers. So we need to come up with clever ways of scoring these muscles as well. And then there's some other abnormalities that I will discuss later on. Now, what is new? Let's just fly by some of the uses of ultrasound that are up and coming. And one of them is the use of oral and bulbar muscle ultrasound to assess swallowing and mastication, so chewing food. So here's an example of what your masseter muscles look like in SMA versus a normal person on the left. They become neurogenically atrophic, denervated, and that will also lead to a whiter muscle and a smaller one. And when we did a study of a population with spinal muscular atrophy, the masseter is affected in a lot of these patients. And the temporalis muscles, another big muscle you use for chewing, is also affected in almost 2/3, while the tongue is less affected. But you can use this to sort of tailor the clinical approach to their, intake. They need to get enough food in themselves to stay healthy. And it might help if you know that there is a swallowing or mastication problem. The same we found in Becker and Duchenne. And the unexpected thing here was that while Becker is usually considered to be the milder version of Duchenne muscular dystrophy or the milder dystrophinopathy, the masticatory muscles were exactly similarly affected between these two types of dystrophinopathy. So it seems to be some sort of early phenomenon in Becker muscular dystrophy, but it's also something that you need to actively ask patients about. How are you doing with chewing food, swallowing? Is there any problem there? And our speech language therapists, they regularly use this technique in guiding our neuromuscular patient cohorts. The other things you can do with ultrasound is every machine has what's called M mode. M is for motion. So you have here a B mode image, brightness mode of this region. The probe is looking up towards the floor of the mouth. And then if you swallow with M mode, you track the movement over this green line. So you see the tongue move back and forth to move the water, in this case, towards the throat. Now, this is a small video of someone swallowing 5 milliliters of water. So here you see the movements, and you can actually measure these movements and see how large the amplitude of the tongue moving is and whether they can swallow it in one go, but this person already needs 2 goes. So that says something about the efficiency of swallowing. And this is a comparative image of a healthy person on the left and a boy with Duchenne's on the right. And you see that there's almost no movement during swallowing, indicating that this is an area of risk for this person. It's also been used in ALS. Then people did an intraoral technique. So you have to have a small hockey stick type probe. You can stick it in the mouth if you cover it with a probe cover. And the gel is on the inside, obviously, otherwise it tastes foul. But you can find higher echogenicities in ALS, and they correlate negatively with the functional rating score. So this is one of the trackers of, again, speech and swallowing functions in these patients. Now, another new development is elastography. So looking at how compressive or stiff the muscle tissue is. And it's been mostly looked at in Duchenne's, but also myositis and myotonia. And this is a protocol that they did in preschool Duchenne boys. You can see the comparative MRI image on the left. You can see that the ultrasound grayscale image is already abnormal. So the top image there is too bright. So just by eyeballing it, you see that this must be a patient and not a healthy kid. And then the muscle is much stiffer if it's brighter, shown in that kilopascal scale there during the elastography measurements. So this might also be a way of showing muscle pathology. You can actually, you look at the fibrosis and the tissue changes. You could also do that with shear wave. So then the ultrasound machine applies a sound wave, and then you measure the speed of that. And that also indicates stiffness. And people have looked at the reproducibility, which was okay if you did it on the same day. So you repeated the measurements on the same day. But if you waited for a day or a couple of days, then the reproducibility was poor. And we still need to find good ways of standardizing elastography, because probably if your patient just came up the stairs or versus he or she took the elevator to your clinic, that makes a difference in what that muscle just performed and how stiff it will be. One of the nicest examples, I think, is this example of a healthy subject clenching a fist and then releasing it, and then looking at the shear wave stiffness, which is, good in the relaxation phase. But then this is a person with myotonia, and you see a much slower release of the tension and stiffness. So this might be a nice way to track myotonia, for example, during treatment trials. So, okay, here is the biomarker part, the core of this talk, I think. Just to show you a couple of examples of studies that have looked into it. This is not exhaustive. There are others. If you did one of them, I'm sorry that it's maybe not on this slide, but we do track your work, I must assure you. And this is just a couple of images from, again, a boy with Duchenne's. So the healthy person is on the left. It also has a very thin subcutaneous layer that you can see here. And then a normal looking biceps and brachialis muscle. You can even see the musculocutaneous nerve right there. And this is a boy with Duchenne's at the age of 8. So that's probably late ambulant or even the wheelchair phase, the early non-ambulant. And this is almost an adult male with Duchenne's. He's 16. And again, no atrophy, big subcutaneous layer because they usually are on steroids and they are not very mobile. And then no muscle fiber left, but no atrophy again. Now, if you follow these boys over time, and we did that in a bit sturdy, I think 10 years ago, and then it was also repeated by, again, the group of Craig Zaidman in the US. So we measured every boy 3 or 4 times over a span of a couple of years. Then you see a very sharp increase in gray value. So the muscle becomes very sharply more white or abnormal if they age. And age here is a surrogate for disease progression. So this is a very high correlation. with gray value and disease progression. And the reverse is true between gray value and the childhood myositis assessment scale, which was a functional rating scale that was used in this protocol. So when function decreases, when echogenicity increases, I should say, function sharply decreases. So this is a very clinically relevant marker for the disease progression. One of our other hobbies at this center is FSHD. I've already shown you a couple of examples of it. We have a very large cohort that's being followed over time. We have the baseline results, the 1 year and the 2 year results coming up, where they get repeated clinical measurements, repeated ultrasound, repeated MRI in some, and then we just track the changes to see what biomarker would be most responsive if you want to do a trial of, say, 6 months, a year and a half max. So these were the first 115 patients, 60 were male. Almost everyone, as expected, had FSHD type 1, and the average age was 52 and the average disease duration 20. But there was a large variation in how affected these patients were. And so there were also 7 asymptomatic and 7 what's called non-penetrant patients. So they don't have any signs or symptoms. And if you're asymptomatic, we do see abnormalities, but you don't experience them. Now here is the average quantitative muscle ultrasound results, and the split between those groups of just normal symptomatic patients. So the ones in blue here. And you see that the average scores are here for at 2 standard deviations or even higher for the arms. So the arms seem more affected as a whole than this is the trunk and this is the legs. But as a group, they are clearly above the mean. Oh, I'm sorry about that. While the non-penetrant, that was very striking, they seem to have better Z-scores. And these were all very active, sportive people. So there might be something in that to see if maybe that's protective somehow, or, you know, we are not sure. It's a small group, this obviously, but it's just to show you that they will show up in these results. If you looked at the visual versus the quantitative scoring in this case, there was a very high correlation. It's a clear disease. If people have it, it's sort of hard to miss, but you will never get 100% correlation between the MRI or the visual or the quantitative ultrasound because of the effects of age and fatty degeneration. So the correlation is about 0.8, which is considered good. And then here is a table showing you the ultrasound correlation to the clinical scores of these patients. Well, there was a high correlation with almost every clinical measure except the 6-minute walking test. And I think that is something that's coming up in different trial protocols, that the 6-minute walking test is used a lot. It's very standard, but it's not very sensitive for anything. So this is probably not a problem of the ultrasound or the MRI for that matter, because you see the same thing there. But it's a problem with the sensitivity of the 6-minute walk test. If we looked at 1 year, what had changed, then we had 218 muscles for that particular study protocol. And then if you did a quantitative analysis, you saw that 41% of these muscles changed significantly. So almost, well, not almost half, but 40% is a big, big proportion of them. If you didn't do the quantitative analysis, but just visually eyeballing the muscle with the HECMAT grading, then 14% had an increase of 1 or more muscles in the HECMAT score. And the other thing was that none of the clinical measures changed at group level, none. So if you want to do a trial, it's probably more useful within 6 months to a year to look at an imaging method than to use a clinical measure. Here are the very preliminary results of the 2-year follow-up, and basically the pattern is just, increasing over time, where more people will go to these higher Z-scores and higher HECMAT grades. So we're going to track this for 5 years, which is well across the span of any clinical trial, probably. Now, if I summarize the use of muscle ultrasound as a biomarker, at this point in time, these are the main areas that have been researched. In Duchenne, you can see changes from the age of 3 on, and usually almost 3/4 of a year before any motor symptoms appear. So it's a good pre-symptomatic to symptomatic screening method. The grayscale levels in these boys, if you are older than 7, so I think the usual trial population, will show changes in Duchenne within 6 months, which is very reasonable in the time frame of a clinical trial. And if you have the young boys who are younger than the age 7, then you will need a year to see that change. But it's always sooner than any clinical measure. And so the same pattern we just discussed for FSHD. And for ALS, something else seems to be going on, because just looking at muscle grayscale will not help you much in ALS progression. It's very variable in the cohorts that have been studied, and there have been studied a lot of patients in these cohorts. But what you need in ALS probably is a composite measure, because ALS is a very complex disease. It's a neurogenic disorder that also affects your central nervous system. And at some point, patients also deteriorate because of respiratory or feeding problems. So there's multiple factors that influence how the patient is doing. And you cannot capture them all in one ultrasound image. But the groups that are starting to look at these composite scores, they do find that they can predict, for example, the progression rate with successfully. So with 81% sensitivity, 91% specificity, if you use a fasciculation score, screening fasciculations in these muscles, and then what's called a median nerve ratio. So you measure the size of the nerve in the forearm and the wrist, and the ALS-FR pre-slope angle. And if you combine those, you get a better prediction model. So I think these composite models are something that we need to look into further and, use across centers, not just the single center studies. Now, there's also new initiatives going on. So a very recent one that they are now actively working on, and I'm helping a bit of this, is the OMERACT study group, who is looking into using visual evaluation of muscle ultrasound for rheumatologists who treat patients with myositis. And they are the first steps that they're now being worked on is how to standardize image classification. So do we have a framework where we can teach people to visually look at these muscles and be sort of have a good intra-observer ratio there? It's a very exciting field, and I'm very happy that this other area of rheumatology is also picking up on the possible advantages of these techniques. So what would we need to implement ultrasound in a treatment trial? Well, for trial purposes, like every test that you do, probably, you need to standardize the acquisition across centers. You don't need the same machine, but you do need a standardized preset that you can use every time you measure your patients. So there is no variability in what the image looks like based on your preference settings or anything. And there are protocols how to do that and get a good dynamic range in the pathology that might occur over time. I think the ideal time frame for ultrasound use would be a baseline visit and then 3 to 6 month follow-up studies. For practical purposes, especially in kids, for example, MRI is usually done at baseline and maybe at the end of the trial. So this might be an ideal tool to fill those imaging gaps, so to speak. And then if you want to standardize the reading of images, you could consider using a centralized reader to grade them all or to solve any differences between local readers. And then for echogenicity here, you can quantify it and you don't need a reference value because the patient will be their own reference at baseline. And you just see if the image changes over time, comparing the patient to themselves. So a few words about muscle ultrasound versus MRI. There's also EMG here, but I left these slides out. If you're really interested, I can show you them at the end if there's time. So we know from earlier work that they are different techniques in the end stages. So here you see an ultrasound and a corresponding MRI image of rectus femoris, the thigh region basically. And on the right, the little graph is showing you that when the Z-score, so the echogenicity increases, the muscle fraction, which is a 2 or 3 point Dixon technique in quantitative MRI, will decrease. So as long as the Z-score is below 0, so below the mean, the MRI fraction will be 100%. And if the Z-score starts increasing, then the muscle fraction will drop. And strangely enough, this muscle fraction will be 0 at some point, while the echogenicity still increases. So probably there are some connective tissue properties of these diseased muscles that still change, even though there's no viable muscle fiber left. Now, There are pitfalls. So MRI, the MRI pitfall is that MRI can't see fibrosis in muscles. And here you have a vastus lateralis image, which just looks okay. But if you look at the corresponding ultrasound, you can see that it's already slightly more echogenic. And in terms of Z-score, it's abnormal. So ultrasound is good at picking up these early signs of fibrosis, which might be relevant for a trial in early phase patients. Now, ultrasound has another pitfall, which is at the end of the disease process, because if you have a fully fatty degenerated muscle like this medial gastroc here, which is really clear on MRI, you can see that the muscle, which is this layer, again looks the same as the subcutis. So it looks like fat because that's what it is. And that gives you a dark image. So actually the echogenicity value here will be low. So in these patients, you need MRI to be more accurate. So they are complementary, really. Ultrasound is good for the early phases and fibrosis. MRI is good for the late stages and fatty degeneration. Now, final few words about deep learning analysis. This is a very active area of research, I think, in every radiology field, and also in muscle ultrasound at this point. So there are basically three things that you would want to use muscle ultrasound deep learning for. First of all, it would be really helpful if the AI could sort of automatically segment your images. The same for MRI as for ultrasound, by the way, but you want to draw an automatic region of interest. And the question is whether the AI learning algorithms can do that. Second one is that you want the AI to characterize the image. Is it normal or abnormal? And so it needs to be trained with what is a normal or abnormal image for that muscle. And then finally, the final step would be, can the AI predict the patient? Can they say this is a healthy person, or this is a diseased person, or this is a person with IBM versus another type of myositis? That's the hard question, actually. So basically, artificial intelligence, I'm no expert, but there are two main techniques that are used. So the first one is machine learning. And basically, you feed the machine a certain algorithm or way to do it with the standardized annotated images, and it will find its own classifiers to sort the images. So this is what they traditionally use to say if an image is a cat or a dog, and it can do that really well. The deep learning algorithm will train itself, and it's a slightly more complex approach. It also needs to be trained, but it will figure out the different elements of an image by itself. You don't need to feed it and say, this is muscle, this is fascia, etc. You just feed the image and it will figure it out by itself. Now we are working with an Italian group from Torino and sending them large amounts of images, as much as we can. And then this particular study we sent them, about 1,400 tibialis anterior, gastroc, and biceps images, and a deep learning ensemble was used to segment the images. And this is what we came up with. The ideal situation is the one on the left, right? So the human observer in that case is green, and the AI is yellow, and they overlap exactly. And just to highlight that these lateral edges of an ultrasound image, you don't want to use them for analysis because there are always artifacts in the edges. So we cut them off. So it's not that neither the human or the AI saw that this was also medial gastroc, but these are always cut off from the image. Sometimes this occurred, so the AI sort of leaked into another part, but when the AI made a mistake, it always selected regions with the same echogenicity. So in terms of diagnostic value, that wouldn't make much difference for the outcome. Now here, the human observer was a little lazy and just drew the tibialis anterior too small, and the AI corrected that. Actually, the correctness is in this table, and the precision and recall are pretty good. So it seems very promising that you could use this to pre-screen your muscles and then have the AI suggest a region of interest, and you just only have to verify it and accept it. And very rarely would you have to correct it. That saves you a lot of time. So when we go to the next step, image classification, so is the image normal or abnormal compared in this case to a Z-score, it did just as well as a human observer. So it was almost perfectly able to sort these images. So that is good news as well. It can classify them and, it can segment them, and then it can classify them. And these were not just healthy people. These were all kinds of neuromuscular disease, all thrown into one big data set. Now, the hard part is, can it diagnose a patient? For this, we used an even larger data set, 40,000 images. 50% of the patients that were in here had a neuromuscular disease. And you can see from the numbers here that the area under the curve was 0.75 or 75% accuracy. That is okay, but it's not great. Strange thing is this number, 75%, keeps popping up in every deep learning study that you see that tries to discriminate between either healthy or diseased or between different diseases. And so here someone used deep machine learning texture analysis, and they found that if they wanted to discriminate 3 different neuromuscular disorders, sensitivity was really poor. But in the case of 2, it was again about 75%. So, and there's been other work on myositis, same thing, 75% accuracy. So there's something going on with just putting images into the deep learning algorithm and expecting it to return a diagnosis. At this point in time, our hunch is that the AI needs more. Just like you as a clinician know, this is a male, a female, he or she is old, obese, has a high a priori chance of having a disease or not. All these patient factors are also taken into account when you analyze an image and a study. And I think we need to also feed the AI these additional data points for it to become more sensitive and accurate here. So that's obviously the next step that we're going to try. This sort of brings me to the conclusion of my webinar. There are some burning questions in this field, and I think they're similar for other imaging techniques such as the MRI. One of the things we really would like to get to is standardization. We would like everyone to be able to use this technique without having to go through a lot of trouble of getting a machine or a preset or a reference set. So in the Netherlands, we are trying as a first attempt to standardize this across 3 centers with the help of funding by a disease muscle for a muscle disease fund. And I hope we can make that work. And we also want to make these automated techniques of automated segmentation and automated discrimination between healthy and diseased available for others via, open source software packages that people can just run in their imaging with their images. We need to look into that diagnostic capability of artificial intelligence by adding extra data, not just the image, but we need patient info in there. And then obviously, if you want to do trials, you need to know what a normal muscle would do in such a patient over the course of time. So we need longitudinal studies in different cohorts and different neuromuscular disorders. And all these are on the agenda, I think, for the next 5 to 10 years. This is what I had to say. I'm very open to any questions, discussions, suggestions. So thank you for listening, and well, let's talk.
Thank you, Nance. It was a marvelous talk and very instructive and very well structured. And you already put some questions to yourself that I was going to forward. So thank you for that as well. I'm going to unmute Amal Ulisan Omar. Amal, do you want to speak out your questions, please?
Hi, I am Amal Ulisan Omar from Gage Hospital. Do you use the TM mode for fibrillations detection? That's my first question. The second is, can US detect the inflammatory parts in muscular dystrophies, like edema, for example?
Okay, I'm sorry to just to ask you to be certain. The first question was if we use M mode to predict fibrillations?
To detect.
Oh, sorry, detect, excuse me. You can, but M mode resolution and fibrillations, I'm not sure how that would add up. So we know that from B mode, just regular brightness, with a high enough frame rate, you need at least 5 fibs per second if you were to stick an EMG needle in and count them. for them to displace the muscle sufficiently for it to show up on the screen. So, and then you also need the right temperature, because at 37 degrees, every fibrillation is there. But if people cool to 32, the normal temperature we use for EMG, for example, then you already lose 25% of the fibrillations, both ultrasound and the needle EMG. So they do need to have more or a lot of fibs for them to show up. And I'm not sure if M-mode will show the same or improve it, but I think if you want to do research, it's a very easy study that still needs to be performed. So thank you for that suggestion, or a suggestion to yourself maybe. And so again, your second question was if we use ultrasound to
detect inflammatory part in the dystrophies.
Yes, yeah, that's a really important question. So I've shown you some of the images, and we discussed myositis and edema. Up front, there's been studies in both myositis and also in patients with intensive care acquired weakness, so acute myonecrosis, you could say. And then almost every study comes up with the same number, about a 70% visual detection rate for edema, which is not zero, but it's not great. In dystrophy, you already have structural muscle abnormalities. We have tried it. We have tried to do it in a large cohort, again, of FSHD patients and muscles. And to make a very long story short, we totally failed. So it was totally random. If we predicted edema, then the MRI would show none. And if the MRI showed it, we said it was just dystrophy. So it might be our first attempt and an experience, but I don't think muscle ultrasound will be the way to go to detect edema in muscle dystrophies. I think you would want a STIR protocol or something for that.
Thank you very much.
Thank you. I've unmuted Frederica Montagnese. Frederica, can you please voice your questions?
Yes, sure. Thank you very much for your talk. I was wondering, do you have experiences correlating ultrasound with the therapy response in myositis? So how quick would you see changes in muscle?
A little bit, yes. So there's some work, it's from a couple of years ago, and this was pediatric in children with dermatomyositis. And you see the ultrasound gets better, or the muscle gets better, if they clinically respond to anti-inflammatory therapy. So they sort of seem to, have the same response slope. So actually, if you want to see if there's a therapeutic effect, and for some reason the patient would not be reliable in terms of the clinical exam, then ultrasound might actually be a good way of validating your clinical impression. The reverse, as we just discussed, if there's a flare-up of symptoms, I would go for another technique like the STIR or the PET-CT maybe even.
Very well. So I don't see other questions, but if you allow me, I have one. So for me, the tricky point, as you said, in fact, is how to standardize and to make sure that your ultrasound machine is aligned with machines in different centers if you want to run a trial in different centers and doing the same evaluation. My question is not, of course, if that is possible. Of course it is possible, but how long does it take? Because it seems to me that's the problem, isn't it? It takes some time to do that.
Yes. So as a very preliminary attempt, I'm working with a trial in a very rare congenital myopathy where we set up standardized muscle ultrasound assessment of two muscles, so just rectus femoris and biceps, for selecting the muscle part for biopsy. That was the only thing that it needed to do. And in the preliminary phase, we spent a lot of time discussing with the different centers how because everyone is not yet accustomed to doing it like that. But then again, you see, once people have actually, taken the probe in their hands and started scanning muscles and eyeballing them, you quickly get a feel for what is really abnormal or what is not. So having a good SOP, standard operating procedure, realigning with the other centers, for example, a basic echogenicity value. So we have, like, we put in there, we want you to have a setting where you have a linear distribution of the echogenicity values. So no time gain controls or whatever knobs you want to turn and twist. And then you need to make it so that the average rectus femoris is like 80 on a scale from 0 to 255. That's very, very basic, but it works because you will have a set of similarly looking muscles, even from different machines, if you do that. So there are a couple of technical things that you can standardize, and yeah, I'd be very happy to, you know, talk and discuss with people up front. And then I think during the process of evaluation, it's very helpful if you have someone as a centralized reader that people can just send their images to and say, hi, am I correct in thinking this is HECMAT grade 2 or 3 or whatever? So that, yeah, that actually does need work. But I think it's not very different from the MRI because you also have different MR systems with different acquisition protocols that at some point also will need to be standardized. And we also need to get away from MRI just eyeballing the muscle and saying, I think it's abnormal, because that's not really, you know, very sensitive or reliable. So there's a lot to do. And actually one of the efforts I was just talking about in the Netherlands is getting funding for this infrastructure part, which is something that is absolutely basic and elementary to, you know, progressing.
Thank you very much. There's no more questions, and I thank you for your exceptional lecture, and hope to have you soon with us in another opportunity. And in the name of the ERN and of our attendants and future viewers, thank you very much for your time, Professor. Bye.
Bye-bye. It was a pleasure.
Bye-bye.